He put a phenomenal amount of work into researching the data that he presented there. I'd next like to invite Dr. Stephen Wexner to the podium. Dr. Wexner is Chief Academic Officer and Professor of Surgery at Cleveland Clinic, Florida, and will be speaking on what I hope is a controversial topic: is there a role for a Center of Excellence?
Thanks very much, and thanks again to the program committee for calling me back to the podium. I'm going to, and my compliments, by the way, Juan, that was a lot of work went into that talk. That wasn't just a literature search. That was a lot of emails and a lot of correspondence, and I hope you publish it, or at least submit it for publication, because it's something that everybody should know, and unfortunately there aren't that many people here who could have benefited. I may do this lecture a little bit differently in that I'm going to also draw some analogies. So in addition to just showing some laparoscopic data, I'm going to show a couple of parallels in our world of surgery. Where's my advance here? So by way of disclosure, I thought the disclosures might be something a little bit different here, because this doesn't apply to using tools so much as creating centers of excellence. And as opposed to my usual list of, Ethicon, Covidian, whatever, this really relates to education and training. And the conflict here is that every organization has the same interest in it. SAGES, ASCRS, the board, the fellowship council, everybody wants to see surgeons get the best possible training. So the conflict might only be in terms of who is ultimately going to figure out how it's done. But the nice answer is we're really all working together in this. And really Dave Schetz is one of the people who is driving this forward as the executive director of the American Board of Colon Rectal Surgery, has put a lot of effort into this Centers of Excellence concept, along with Dave Rothenberger from Minnesota and Pat Roberts and others, and we've been working together amongst these groups. But the end result is quality is never an accident. It's always the result of high intention, sincere effort, intelligent direction, and skillful execution. Represents the wise choice of many alternatives. Now, we might add to that it also represents a team effort of many people who, although we all wear different hats, we do primarily represent different groups when around a given table. And the good news is we're working together at it. Now, I said I would probably like to draw some parallels, and this is a parallel that doesn't always go over well depending upon the audience, but the issue is that we understand that outcomes are contingent upon two factors. One is training, and the second is volume. So if we look at the variability in rectal cancer, and there's no reason to believe that laparoscopy or laparoscopic treatment of rectal cancer is any different. If we look at some Canadian data, we see that there are 52 surgeons, 5 of whom were colorectal surgeons in this particular study. And the way this laid out was firstly to look at the demographics of the patients. And the patients operated on by colorectal surgeons were more likely to have lower tumors. However, despite having lower tumors, they were more likely to have had sphincter preservation and less likely to have had abdominoperineal excision, whereas the converse was true when these operations were performed by people who didn't have formal training. Well, you say, okay, but what if you're cutting a corner and doing a low anastomosis and subjecting that patient to a higher risk of a local recurrence? So what? You're doing sphincter preservation, but you're not doing oncologic surgery. Well, it turned out that actually the converse was true. Now, here you can see that a surrogate for training is volume. So if you look at somebody colorectal trained doing a high volume of resections, their local recurrence rate was the best, 10.4%. If you looked at somebody who was colorectal trained doing a low volume, their outcomes weren't as good. The same held true for non-colorectal trained surgeons, 27.8% local recurrence versus 44.6%. And in a multivariate analysis, training was an independent prognosticator, a very strong one. You could see the hazard ratio of 2.5 actually trumping use of adjuvant therapy and lymphovascular invasion, which we know are very important issues. However, volume was also important. There are two issues at play. One is training and one is volume, and often the two work together. Similar data were found in the United Kingdom with both univariate and multivariate logic regression analysis. Local recurrence was independently determined by training, and you can see, read the conclusion for yourself from Helen Dorance's paper, and another more recent UK study. These are specialists. So these are not necessarily people who did formal training, but people who have an interest and continue to practice a high volume of colorectal cancer surgery. And you can see that their specialization, with or without specialty training, but their specialization and their commitment to do colorectal surgery gave patients many, many advantages. And remember, when we talk about colorectal surgery and we think about the volumes of cases being done, as we saw in the earlier talks, a lot of these operations are being done for cancer. So it's important that we heed these issues. In the state of Maryland, what was found in Harmon's study was that surgeons, medium volume surgeons, could get very good outcomes similar to high-volume surgeons as long as they were in medium or high-volume hospitals. So that's like the old adage that rising tide raises all ships. If you're in the environment where you have multidisciplinary team approach, where you have morbidity and mortality, constantly assessing these outcomes, when you've got residents who are cross-pollinating services, you can actually up the bar. But if you're not doing a lot of this type of surgery, you probably are not doing a favor to your patients, because the low-volume surgeons, even working in the highest volume hospitals, never got the same outcomes. And there's a lot of studies that look at these issues. This is volume. This is not training. This is not saying, I've got a couple of hats. This is not saying it's necessarily a given fellowship, but this is saying you have a commitment to dedicate your practice if you're doing this type of surgery, which is what a center of excellence is, in part. It is multifaceted, but in part it's the surgeons dedicated to whatever it is, pancreatic surgery, carotid surgery, bariatric surgery, to look at these issues. And there are many studies that show these issues to be true. Looking at a meta-analysis that was just published the end of last year, 23 articles on colon and rectal cancer, and you can see, or you can almost see, that the diagram clearly shows in favor of high volume for better outcomes in every single parameter assessed. Mortality, very importantly, survival, and again, survival, mortality for colorectal cancer. Clear and consistent relationship, volume. Okay, so both important, volume and training, but that's what constitutes the beginning of a center of excellence. Now, the other issue that relates to that is, how are you doing it? And there are different ways to do it, which, you can do it repetitively, not the best way, but if you're in a center of excellence, you're going to be held to a standard that you have to do things a certain way, whether it's bariatric surgery, carotid, pancreas, whatever it happens to be, it has to be a certain way. And the way rectal cancer should be approached, in part, is total mesorectal excision. I mean, there are other things. There's when to know when the patient should get neoadjuvant therapy. There's when to do local excision, when to use TEM, all the rest of it. But take something simple that we now understand, total mesorectal excision. And the way this study was constructed, you can see that in the earlier time period, compared to the later time period, there are about similar numbers of patients, and they're similarly stratified. And the way this waterfall kind of works is, in the earlier period, nobody knew how to do TME, and their local recurrence rate was almost 20%. Then Bill Heald came along and showed interested surgeons with the commitment how to do TME. Those surgeons adopted the technique and were able to show in their patients a local recurrence rate in the second time period of 6%, whereas the surgeons who didn't learn and just kept doing the same old thing still had a 20% recurrence rate. So the country of Sweden declared centers of excellence for rectal cancer based upon surgeons engaging and being subject to audit for the technique of total mesorectal excision. Well, laparoscopic surgery is very similar and very analogous, and is often applied, obviously, is often applied for the treatment of rectal cancer. As we've heard, that seminal date in 2004, 2005, suddenly we saw a tipping point where people read the cost trial, heard Heidi Nelson's presentations, and felt it was safe to put a toe in the water for colon surgery, even if not as many people as we'd like. And rectal cancer is following suit with Jim Fleshman's COST-2 trial and Jaap Bonder's COLOR-2 trial and some of the others. This particular study was structured looking at the 2 senior trainees, 140 resections, first assist, plus performing these operations. And you can look and see that these skills can be acquired pretty readily. I mean, there's not great numbers of cases, but adequately trained and supervised trainees can perform these operations. There's no doubt about it. But they have to have a commitment to it. And you have to realize that when some of the recertification data have gone out. I mean, again, these may not seem like big numbers, 71 operations. But when you look at data, for example, published by Wallace-Ritchie for candidates sitting for recertification for the American Board of Surgery exam, and you realize that the mean number of cases reported is 7 colon resections in a year, that would be 10 years worth of operations, and that is not going to get somebody to participate in a center of excellence. Pat alluded to some of these data earlier in terms of laparoscopic cases, and Dave Schetz gave me a couple of these slides to put in here. Here are some of the different operations that are done by the trainees in the programs, which are reviewed by Rick Weiss and the Residency Review Committee in colorectal surgery, and you saw this graph already, but I think repetition is sometimes helpful. The number of cases have certainly gone up for abdominal laparoscopy, and you can see the types of cases being done laparoscopic or open are up to 24%. We can, with laparoscopic surgery, when it's done in high volumes by well-trained people, actually confer superior results. We know that. We wouldn't be here. The society would not have had explosive growth the way it did if we weren't conferring obvious benefits. And it's beyond the benefits of less pain and getting out of bed quicker and going home quicker and better cosmesis. It's cancer, too. And Antonio Lacey showed that. Very different results than we saw in the Costa or the classic trial with lots of people doing a few cases each. I mean, here you have somebody doing 217 cases for cancer, and can the slide advance, guys? 217 cases, and I mean, we're all very familiar with the outcomes for overall survival. This is giving me trouble. Can you advance? Anybody? Yep, okay, no, sorry, go back. Thanks. You can see here that cancer-related survival, you start to see a divergence in the lines. Advance it, it's just ceased functioning. Okay, advance, please. But you can see where that break point is with the stage, I was using, sorry, this thing just clicking the left, it's just sort of, okay, try again. That for the, you can see the break point there in the stage 3 cases with the survival advantage. And those results, no, it's still not doing anything. Those results are significantly different, you just got it, than we got when we had the cost trial, or Europe had the color trial, or the UK had the classic trial, where a lot of people did a couple of cases each. Same thing from Italy. I don't know that people are quite as familiar with this one, but Mario Marino, who's the chief of surgery, professor of surgery at the University of Torino, very well stratified groups, though not I'm going to touch it, not randomized controlled trial, but a well-matched cohort, decreased local recurrence rate, okay? So 3.2% as opposed to 12.6% when being done in a high volume by somebody with a commitment to it. Again, that's different. Look at the results that we had here when everybody was doing a few cases each, 48 institutions, 872 patients. I mean, you can do the math pretty quickly. Well, you can. I'm not that quick, but you guys can do the math and see what that comes out to be, plus a 21% conversion rate, and help. And you can see those graphs look very, very different than they did for the study from Antonio Lacey from Barcelona. Just next. Same for overall survival. Next, please. So absolutely no benefit in the oncologic sense. And again, the people in that study were all committed to doing laparoscopy and committed to colorectal surgery, and some were ASCRS members, some were SAGES members, some were both, some were neither, but all these people were doing enough and had enough interest to be where Pat showed us all the way on the left-hand side of the graph is innovators. I mean, this trial started in 1993 when we wrote the trial, and patients enrolled starting in about 1995. So these were very early adopters, clearly with an interest, but not with sufficient volume to really be excellent. Next, please. UK, same. Next, please. Same. Again, you just do not see the differences when it's being scattered all over the map and not being done in high volume. Can we advance again, please? So what David Jane recently published in follow-up to the initial classic trial, the 5-year analysis, still safe, but not seeing that benefit that we saw in the so-called centers of excellence like in Barcelona. We're seeing how that works for rectal cancer, and sorry, go back. Thank you. Using a 2-to-1 randomization schema, relatively recently, released the early results of the COLOR trial, showing that the groups are very well stratified. We don't yet have oncologic data. You also saw earlier on in John Marks's talk the COS2 trial, so I'm not going to repeat it. That's underway at a 1-to-1 randomization. So the issue is there's lots of ways to skin a cat. There's many ways to get there. Whatever you're doing, you have to audit it continuously. You should, at the very least, maintain a registry. You should put your data, whenever possible, in publication in a means that Juan and others can find it, that it's index medicus. Whenever possible, participate in trials if you're in the early innovation group or if you're in the early adopters group, so that everybody can benefit from the experience. But if you're going to be a center of excellence, you've got to be excellent. It's not just a matter of getting a certificate to hang on a wall. It's a matter of making yourself open to public scrutiny and public domain for your data all of the time, and it's a commitment to whatever it is you're doing. You have to accept the fact you cannot be a master of everything you do. So you select, and if you're going to be the master of laparoscopic surgery, you're probably not going to be doing a lot of other things. If you're going to be a master of rectal cancer, you're not going to also be a master of 30 other things. You're going to have to select what it is. But it's not necessarily strictly training related. Volume plays a big role, and it's a team effort. So it's working, in the case of rectal cancer, with a multidisciplinary team, with medical oncology, pathology, with radiation oncology, and postoperative management for fast-track protocols. I didn't even get into that, but it's a team effort. It's not up to us on an individual basis. We absolutely can do it, but more importantly than that, we need to do it as we go forward, particularly with laparoscopy for rectal cancer, where we can make a huge difference. We're not just talking about when people get out of the hospital and when they go home and eat. We're talking about cure of a rectal cancer versus recurrence of that cancer. Thank you very much.